Okay, so I made some handouts for you. All right, so we're going to go through the safety. Now, safety is the basis of all of nursing school. This is a very, very important module, which is why I wanted you to come in person. Okay. Like when you take NCLEX, they're going to ask you safety questions first. And if you get those wrong, you will not pass. Because the number one thing, you have one job when you go to the hospital. Don't kill anyone. Okay. And that is where safety is the basis for. So this is very, very important. You'll be tested on this in multiple classes. Okay. So typically on my modules, like I said, I think they emailed you and told you we're redoing this course.
Yes.
Right? Okay, so you'll see like some old things as we're doing new things. This one is a whole new module.
Okay.
So I try to do cheat sheets. And the reason why is because if nothing else and we're short on time or it's right before your test, you can go through the major stuff. Okay. In front of you here too, you'll see you can use these highlighters, which I would recommend. Markers, write down whatever you want to write down, just like things that are going to help you. Most of the time, the students will use tons of Post-it. So if I say a word that you don't know, write that down, put it on a Post-it, and then as you learn it, you take off the Post-it and it goes in the trash. So your goal is by the time you get to the exam that you don't have any more Post-its left because you already know all of the answers. Okay. All right. So this is this is the whole module in one page, and then we're going to go into detail on each one. Okay. All right. So remember we said you had one job, right?
Yes.
What's your one job?
Don't kill anyone.
Okay, let's keep them safe. All right. So safety is a huge big deal because not only is it a major JCO issue. Have y'all studied about JCO or know what that is?
No.
Okay. So it's actually let me write it down for you really quick. Because I know, and if there's anything I say that you're not familiar with, you don't know yet, then just tell me because I don't know what you know yet. I'm still learning you. So it actually looks like this. JCAHO. Okay. That is the accreditation process. So every single hospital, JCO will come out there and you'll hear the nurses talking about it because if they're there, they're watching your every move. Did you wash your hands? Did you bring a drink out to the nurse's station? Okay. And so people will be like, JCO's here. Oh my God, JCO's here. JCO's here. Okay. So safety is a big JCO issue. Okay. So the first two is Joint Commission.
Okay.
But everybody calls it JCO. So safety is a big issue because if you do something that is unsafe as a nurse, your hospital does not get reimbursed for the care of that patient. Okay. So if you have a patient that's in the hospital and they've had a stroke and you're taking care of that patient and they fall out of bed and break their hip and they need surgery, the hospital has to swallow that cost. Okay. You're not getting reimbursed. And that's because you as a nurse, whose fault is a fall?
The nurse.
It's yours. Even if the patient is confused, even if they jumped out of bed and jumped over the side rails, it's still your responsibility. So this is a very, very big issue. Okay. So you'll see up at the top where it says safety and security are basic human needs. That's a Maslow's thing, right?
Yeah.
You have learned about Maslow's. What'd you learn about Maslow's?
It's the pyramid from the very bottom. I believe that's the priority. They have the biggest priority.
Yes.
All the way up to the top, it's all basic needs, but
yes,
it slowly decreases in the priority.
Absolutely. So safety and security are one of the most basic needs on Maslow's hierarchy. Yes?
Yes.
All right. So it is your job and the hospital's job, okay, to produce a positive safety culture. Without like reading too much about it, what does that mean to you? Or what does that sound like to you?
That all patients and yourself, the staff, have to be safe when handling anything.
Yeah, and you're all like helping each other out. Like, hey, your patient over here, she keeps climbing out of bed. You want to do something? You know, like y'all all help each other have a culture of safety. So what is included in that? Okay, you have openness and trust without blame. That is very important because a lot of nurses now are afraid to admit that a mistake was made. How come?
They can get in trouble.
They can get in trouble. You could lose your license or you're going to they're too afraid. So you want to work for a hospital that says like, you know what, mistakes happen and that really stinks and we can work to make sure that doesn't happen again. But we understand that things like that happen. Okay. Now, how many hospitals have that characteristic? The first one.
Oh.
Not very many, right? Yeah. Not very many. It's hard to find one because, you know, they want to blame everybody. All right. The second part of having a positive safety culture is resource allocation. What does that mean to you?
I'm not sure what allocation means. I guess that there's a lot of resources in the hospital.
Okay, and they know where to put those. So to allocate something means, okay, so let's say 5 of nursing students from your class come in and I have 2 pizzas. Then I'm going to allocate some to this person, this person, this person, this person, right? And this person, there's 5. But what if one of the people came in and was like, Carl, I'm such a poor nursing student and I have not eaten since yesterday. Would I give a little more of the pizza to her? Okay, so that's what resource allocation is you're allocating what resources you have and you're doing that properly. So for instance, how do we apply that to safety? You want to work on a unit that, let's say you have an 89-year-old man who has a history of Alzheimer's. He's here admitted with a UTI. How altered do you think he is? Very altered. Okay. So, and you have 6 patients that day. Are you going to be able to spend enough time with him to make sure that he's safe?
No.
So what would you ask for?
Probably another nurse to help you with.
Well, she's not going to be able to, right?
Right.
UTB does a very good job of this. That's probably the only hospital team that does it. You can ask for a sitter. Have you heard of a sitter?
Oh, yeah.
Right?
Yeah. Okay.
And be like, look, this man is going to fall. I already know it. He's been jumping out of bed all night long. The nurse that came, that relieved me told me that. So I would ask for a sitter. Now they have to pay. The hospital has to pay for that. Okay. But you want a hospital that's good with resource allocation, right? All right. Errors are explored and systematic weaknesses identified. What does that mean? Very wordy for what? What does it mean?
I guess just any errors that you do make, when you do take the blame for it, you explore what happened wrong, what you need to do better, what needs to be fixed so you don't make it again.
Beautiful. So it's a hospital that says like, hey, this mistake happened. What did we all do wrong as a whole that led to this, right? Because it really isn't fair to just blame the nurse for everything. And that's really what happens, right? Medication error, whose fault is it?
The nurse.
Even if the doctor wrote the wrong order, right? A patient falls, whose fault is it?
The nurse.
Exactly. But in a great hospital that has a positive safety culture, you will see like, okay, what happened that day? And they're like, oh my God, a nurse called in. We didn't have another one come in. So Deepa had to take 7 patients that day. And there was no way to spend enough time with this patient. We couldn't get a sitter because it was, storming outside and nobody could come in. And they're like, okay, well, what do we do when this situation happens again? Okay. Could we have put 2 people that needed a sitter close to each other in the room and the sitter sits right outside? Right? So you kind of try to find out what could we have done different. And then the last one is transparency and accountability. What's the difference between the two of those? What does transparency mean?
Being transparent. Well, I start with accountability, but being accountable is just that you made the mistake, you take responsibility for it.
Yes.
Transparency, I guess, maybe you understand what you did wrong.
You can understand, but also you let people know like a mistake was made here.
Okay.
You've seen a lot of hospitals that try to cover up their mistakes, right? And with transparency, especially with safety, that's me calling the family and saying, hi, is this Mr. Jones' daughter? I am so sorry he had a fall overnight. We were short-staffed and we didn't have enough nurses. I am so sorry that this happened. That's being transparent and open, okay? How many do you do TikTok? Are you a TikTok person?
Yeah.
Okay. So I've seen a ton of TikTok videos where like people are saying like, oh my God, I walked into my mom's nursing home and she's got a black eye and they didn't call me. And then I finally asked them, I was like, what happened to her? And they told me she fell 2 days ago. That's not being transparent, nor is it taking accountability.
Right.
Okay. All right. So you as the nurse, what are you responsible for? Your safety assessment. So we're going to go through what we would assess in our patient in each of these categories. So I'll name out the category and you tell me what kind of questions that you might want to ask or things you might want to explore in that area. And I'm not expecting you to know every single one of these. Okay. All right. Developmental. What does that mean in a safety assessment?
Is there any problems that can lead up to for the patient that will injure the patient? Or
like what? Give me an example.
Like with the side rails, what if and if the bed is really high and they probably only have like one side rail, then that both problems are wrong and it can lead to something really dangerous for the patient.
Okay. So if you're looking at how they're developing, that's what we want for developmental, right? So let's say you have a 19-year-old patient that comes in, but mom says, you know what, he has cerebral palsy, so mentally he's more like a 7-year-old. Okay. So you would need to know this is a grown man physically, but he mentally is around 7 years old. What would I do for a 7-year-old in bed? I'm going to keep the side rails up. I'm going to talk to him often and let him know, don't try to get out of bed. Right. So you have to look at, is there any developmental delays that you need to take into account? Okay. You've heard of a lot of kids with autism and some of those kids are runners, right? They like to, as soon as they want to escape, they take off. I need to know if a kid has autism because developmentally, I'll know to ask the question, is he a runner? Because he may just be able to see, oh, no nurses in here. And he takes off down the unit, gets into the elevator, and where did he go? Right? Okay. All right. Their lifestyle. How does that go into their safety assessment?
This can be like social factors. Well, that's a different thing. But like economic factors, maybe probably if they're unclean or things like that, or so they have a messy room, and then that can be unsafe for the
Sure,
patient,
sure, I can
like
agree with that.
messy cables and things like that, or their table area when they need to eat, it's messy,
Yeah.
and that causes
What if
discomfort.
you went out on a date with somebody that you met
Mm-hmm.
and this guy's like, "Oh man, I bungee jump and I cliff dive
Yeah.
and what, sir?" Okay.
It's a lot.
So their lifestyle is very
Like
risky,
energetic and
very
risky.
risky, right? So you want to look and see like what kind of thing, what kind of car do you drive? Is it a safe
Mm-hmm.
car? Is it not a safe car, right?
Right.
What about occupation?
Just any work hazards they have in
Sure. So
knowledge.
like construction
Mm-hmm.
workers, right? Plant workers often have very dangerous jobs. The I'm gonna look stupid when I can't remember what their name is. Who are the guys that climb up the telephone poles?
Um.
You know what I'm talking
Yeah,
about.
yeah,
Okay,
yeah.
yeah, things like that. Okay. So you want to look at their occupation.
Mm-hmm.
Now social behavior. What does that look like?
So maybe they just don't like talking a lot, and so they just are quiet.
But you want to relate this to safety.
Um,
What do you do on the weekends? What do you do?
resting.
You rest on the weekends? Oh, that's nice.
So I'm trying to
What do
say
most college students do on the weekends?
partying and
Okay, so
drinking.
do you drink alcohol? How much do you drink? Do you
Mhm.
drink and drive? Do you smoke? Do you smoke weed? Are you impaired in any kind of way? So I want to ask like what kind of social behaviors they have that might put them at risk for something unsafe.
Okay.
Okay. All right, now let's look at their environment, and this would be their home environment.
Mhm.
Okay, what kind of safety issues might you see there?
Maybe if like leading to abuse, if any
Okay, so if there's domestic
abusive.
abuse, I
Mhm,
definitely can
domestic
agree with
abuse.
that.
Also, they don't have proper safety. If it's an older patient, they don't have proper accessibility devices
Oh,
at
sure.
home.
Mobility devices,
Yeah.
yes, or safety devices. I can agree with that too. If they live in a crime ridden neighborhood,
Mhm.
right? If they're hoarders, you know what hoarders
Yeah.
are? Okay, that's all scary. A
Mhm.
home environment that's scary. All right, what about mobility safety assessment? What might that look like?
When they're in the house, or when they're in the hospital and they don't have grippy socks, or they don't have a cane if they need it,
Okay.
any walking devices that
So you want
they
to make
need
sure
it.
that their devices are right next to the bedside
Mhm.
so they don't go reaching for them. And you're
Mhm.
right, grip socks are a big deal. All right, why am I assessing their sensory perception? First of all, what does that even mean?
I remember seeing this in the first exam. It was like sensory deficit or
Mm-hmm.
sensory overload.
All right, so what does it
So
mean? What are your
so
senses?
the five senses:
Mm-hmm.
smell, touch, hear, see, and taste.
All right. So if those are altered, now
Mm-hmm.
taste is not as big of a deal,
Right.
right? Okay. But the touching part or the feeling part is a big deal. So let's say they have diabetes and they can't feel very well from their knees down and they try to get
Mm-hmm.
out of bed.
Yeah, will cause problems.
Yeah, they're probably gonna fall,
Mm-hmm.
right? So if they have any sensory perception deficits and can't feel something, that could
Mm-hmm.
put them at risk of something very unsafe.
Right.
Also, things like bed sores if they can't feel very well,
Mm-hmm.
right? Or they may not feel the hot or the cold or that something's bothering them, right?
Mm-hmm.
All right, what am I doing as far as a knowledge assessment for safety? What do I want to know what the patient knows?
Probably when you tell them that you need to have the grippy socks when you go pee in when you go pee,
Mm-hmm.
and if they don't understand why it's important, then that causes problems because
Sure.
they won't put it on.
Okay, that's a good point. Yeah. So, if do they have the capacity to understand what you're
Mm-hmm.
saying and why you're saying that those are important,
Mm-hmm.
right? And then, what is their knowledge as far as do you have a safe home environment? Can you tell me what your home looks like?
Mm-hmm.
And some things that I would always ask the patient, like, tell me 3 things that could be hazards in your home that we're going to take care of before you go home. You'll get your
Okay.
family to do that.
Mm-hmm.
So I'd be like rugs. They hate rugs in nursing school.
Mm-hmm.
Okay, it's always take down everything. Rugs are a big demon. Okay.
Mm-hmm.
All right, what am I assessing as far as their communication ability? Why is that important?
Mm, is this probably about like do they understand what you told them about safety hazards and any safety risk at home or at the hospital?
Mm-hmm.
Do they can they like repeat it back to you?
Sure. So, like, what if they've had a stroke and they have like receptive aphasia?
Mm-hmm.
And then you're telling them, like, do not get out of bed. If you have to go to the bathroom, you need to tell me. And they're just like, uh huh, uh huh.
Mm-hmm.
But they do not understand what you're saying at all. You have
Yeah.
to make sure they either verbalize it back to you or they may not be able to do that. So, you may have to get something like a sitter or a family member to stay. All right. Their physical health state, how does that play into their safety?
So, uh, so if they do like faint a lot, then that cause problem. Maybe if they go to the restroom, and their blood pressure is really low or really high,
Sure.
they will just faint and it causes
All right, so blood pressure issues could cause a problem. Diabetes and sensory perception could cause a problem. If their blood pressure is too high, right, they might often feel dizzy as well. So their physical, like how well are you able to get out of it? How sick are you? That does play a big role into their safety. Okay. So the 4 big things that you look for as far as safety on the unit is we have to assess the person, their environment. Are they a fall risk? And is there a fire risk? Now, who's a fire risk?
Oh,
and especially if they're on oxygen.
Okay,
they will try to light up in their bathroom. They will try to light up in their room. And if they are lighting up and there is oxygen, what will happen? It will blow. So you have to be very, very careful. And they may tell you, like, oh, yeah, I get it. I know not to smoke. And they don't understand how big of a deal it is. Like, they will explode on fire. Okay. So speaking of fire, this is really big over here. This is the order at which you take care of fires, right? Now, there's different ways that we will do this. So I'm going to explain this one first. So race, we know, is to rescue anybody who is literally on fire. Okay. So if I see a fire erupt right behind us, what am I first going to do? I'm going to be like, oh my God, girl, come in here. Yeah. Right? We're going to get away. That's what rescue means. It doesn't mean to evacuate the unit yet. You're not there yet. Then you're like, okay, nobody is on fire. Nobody is right next to the fire. So now I'm going to go and pull the fire alarm. Okay. To confine. Do you know what that one is?
Oh, capture. Like, wait.
What is it? If I was putting you in confine, like, yeah. So that's when you are going to go all up and down the unit, closing all the doors of every single patient. Okay. And this is if there's a small fire. If we have to evacuate, that's a totally different ballgame.
I think that's the UTMB, our little badge says contain instead of.
Oh, contain. That's fine too. And then extinguish, then you're going to go and put out the fire. Okay. Now it's different if you have to evacuate the unit. If it's a big fire or the fire alarm goes off and they're like, everyone needs to evacuate this hospital. You're like, okay, then I'm not going to shut everybody in the rooms because we're evacuating. Right. Who do you evacuate first?
If it's like a big fire.
Big fire, we all have to evacuate.
Yourself.
Girl, you can't leave all your patients there. She's all, peace out, y'all. Good luck, though, okay?
Okay, all the patients. Help the patients first.
But who? Which ones are you going to pick first? Let's say you've got 35 patients on your unit. How are you going to...
People with really bad mobility.
That's what I thought too when I was in nursing school. Okay. No, they're putting the easy to get out people first.
Easy to get out.
Okay. So if you can walk on your own, you're going first.
Got it.
Why? Because I can get the majority of people out that way. How long is it going to take me to get a wheelchair confined with multiple lines on an IV, on multiple IVs, who's also connected to a monitor? How long is it going to take me to evacuate that patient? A long time. So I need to get out the quick people first. Okay. And that never made sense to me in nursing school. Yeah. Right? Because you're like, you would think like that's kind of rude to leave all the bad people. But it kind of makes sense once you think about it. Like let's say you've got 35 people on the unit and 20 are ambulatory. I'm going to get rid of those 20 really quick and then start working on my 15. That's right. And you do the easiest ones first and then you keep going harder and harder and harder and harder. Okay. Because if I go to my most critical patient, that's going to take the entire time and all the other 14 will burn up.
And okay. That just means mobile, right?
I know. I never understood that in nursing school either. I'm like, why they keep saying this ambulance? Yeah, ambulatory means I can walk. Okay. All right. So do we understand the difference in how you handle fires?
Yes.
Okay. So these are just big testable things that I've seen over and over and over again. Side rails up ×2 only. 4 is considered a restraint. Yes.
I thought it was 3 actually.
Nope, 2.
2.
Side rails up ×2. Now, even 2 can be considered a restraint if the person is really small and like can't get out of there. Right. But typically, we just don't do side rails up ×4. They'll climb over it anyway.
Yeah.
Okay. And then put on grip socks. I already heard you say that. They hate rugs in nursing school. We either tape them down or completely get rid of them. Yeah. Okay. And the priority question for safety is always to orient the patient. Orient them. If they're like, how do you keep a patient from falling? You tell them where they are. Because if you think about it, let's say you've got a patient with Alzheimer's and a UTI. Okay, he's an 80-year-old guy. He has no idea where he is. You wake up, you have no idea where you are. You're sick. You're around people that you've never seen before. Do you know what a nightmare that is? Yeah. Like, if you went to sleep tonight and then when you woke up, you were in an unfamiliar place. You had no idea where you were. Aren't you going to try to escape? Yeah. Like, I've seen this movie before, right? Okay, you're going to try to escape. So the more you orient hi, I'm Deepa, I'm your nurse today. You were in an accident or you have you're here with an infection. I'm here to take care of you. Then they're not like, okay, I'm not in a Saw movie. And I can actually, I can breathe. So orient them every time you come into the room and choose that before you do anything else.
Got it.
So then they know.
It's like just tell them like the situation.
Yes, like here's who you are, here's who I am, here's why you're here. You've probably seen it on. Do you watch Grey's Anatomy or no? No. Okay. No, I know. In pretty much any hospital show, they'll always say like, "You're okay, you're safe, you were in an accident," you know, so that because you gotta think how scary that is to wake up, especially if you got them in restraints, and they wake up tied to a bed. That's my worst nightmare. Thank you. Right? Okay. All right, let's see what else. Medication safety. These are just little things to note. No ipecac syrup. Do you know what that is?
No.
Okay, so whenever a kid used to swallow something, okay, we would give them something called ipecac syrup, and it would make them vomit. It would induce vomiting, and then they would throw up whatever that agent was. What they found over time is that, let's say the kid went and took some bleach and drank it.
Yeah.
Well, bleach is going to burn the whole inside of their esophagus. But what happens if I make them throw that up?
It'll still hurt.
It'll burn again.
Yeah.
So we do not give ipecac anymore. It's just not in practice. Okay. Keep meds in a locked container out of reach. That's for kids, right? And as soon as if they've intaken anything, you call poison control immediately. Like before you call 911, before you go to the ER, you always pick poison control. Even because if that patient goes into the ER, the nurse will still call poison control because we don't have a book with every single thing that you could possibly take. It's poison control that we call first, so we know what to do. Okay. All right. Do not document in the chart that you filed an incident report. What's an incident report?
Any accidents you make in the hospital.
All right. So something bad happened. Somebody fell. You done messed up. Okay. Now, why do I not put in the chart incident report filed?
It just needs to be a separate report.
But why? Why would you not want to put it in the documentation?
I'm not sure.
All right. So let's say you were on shift. A patient fell. You know you messed up. Okay, you were supposed to go in there and check and you missed it. You were busy or whatever, right? Okay. You have to file an incident report, meaning like the patient fell. I messed up. Okay. If I put in the patient's chart, filled out incident report and filed it, that's a permanent part of the patient's chart. If they decide to sue the hospital, anything in the patient's chart, they can subpoena those records. So if you've written it in the chart, they can also subpoena the incident report. And filling out an incident report is basically admitting you made the mistake and it's your fault.
Okay.
Do you see what I'm saying?
Yeah.
So when you're documenting it, you document the bare minimum. Patient fell out of bed at 2:46. Patient was assessed. Vital signs are normal. Doctor was informed.
Okay. So then, is this kind of like saving the hospital?
It's saving the hospital's butt. That's why it's always on exams. Okay? Because if you put in their chart, filed an incident report, that attorney can then go and subpoena your incident report. If there's no mention of it in there, then they can't subpoena something that isn't there. Even though it is there.
Right.
I know. Okay. So you never put in the chart that you filed it in. You still have to file it, but you don't put that you filed it. Okay. And you don't take responsibility in the chart either.
Okay, you don't say you did. Okay,
you just say this is what happened. The patient climbed over the side rail and he fell, and that you just document that he was okay. You notify the physician or the charge nurse or what have you. Okay. All right. General safety things. The bed should always be in the lowest position and locked with side rails up ×2. Call light within reach. Remove any floor clutter and grip socks, glasses, and hearing aids within reach. That's a lovely select all that apply.
Yeah.
Okay. They're like, how can you keep your patient safe? This is the bare minimum.
Yeah.
Okay. As we're sending them home, they should have nothing on their floor, which that doesn't happen in any patient home, but okay. Remember rugs? Big no-no. Okay. Always choose adequate lighting so they can see and they don't trip on anything. You want to ask them if they have any firearms in the home or space heaters. Space heaters are notorious for causing fires. Do you even know what those are?
Is this like just a portable heater?
Yeah, but a lot of times like in New York and stuff, they're actually like connected to the wall.
Okay.
But they get really hot. And so if you put anything on it, it can just start a fire.
Okay.
So you always want to ask about that. Grip bars need to be in the shower and the bathroom over the toilet, so that way they don't fall that way. Okay. Now restraints, what I listed on restraints is the biggest testable things. I'm going to go over it in much more detail in a minute, so I'm just going to hold on to that for now. Do you have any questions so far?
No.
All right. Why are we so obsessed with falls and preventing them? What did you learn today?
Just want to make sure that the patient's safe. And
what happens if they fall?
It gets back on the hospital.
It goes back on the hospital. They don't get reimbursement, and it looks really bad to Jaco. Okay. So also, we care about the patient, but the hospitals are really big on this. Okay. Top 5 causes of falls. So these are, you need to identify these to know like my patient's at risk. Okay. So if they can't see well, right? So if they have either cataracts, glaucoma, diabetes can also cause bad vision, right? If they can't see well, then they don't know what is safe on the floor, right? So if they have impaired vision, that's an automatic, like, they're at risk. All right. Home hazards. Don't read it. What did you learn are big hazards at home? Rugs.
Make sure good enough lighting.
Good lighting.
Good handlebars in the bathroom.
Yes.
Shower.
Grip bars everywhere. And then you said something earlier that I didn't even mention, but talking about like being having it accessible.
Oh, right.
So like if you have a wheelchair, you want to make sure that there's a ramp, right? Those kind of things. Okay. Medication. So a lot of drugs make people sleepy or dizzy. So like opioids, which treat what?
Treat pain.
Pain, yeah. Any sedatives, anti-anxiety meds, all of those can make you dizzy. They can make you faint. They can make you altered, and that puts you at risk of falling. All right. Weakness or low balance. So this could be anything from older adults who just typically have, lower muscle mass to these people are really sick, right? Or this woman has just had a baby, right? And so her balance isn't super great right now, okay? And then any chronic conditions. The more chronic conditions that you have, the sicker that you are and the more likely that you are to fall. Okay? Do we understand all that? All right. And then if you see down at the bottom, 1 in 3 adults age 65 and older fall each year. So it's important for us to not only make sure they don't fall in the hospital, but we do an assessment for them at home to see what we can do to make sure that they don't fall at home. Okay. All right. Do we understand causes of falls?
So for the chronic conditions, that kind of goes into the weakness, basically.
The weakness, yes, and they just don't feel well. Typically, like, okay, let's say they have heart failure. They're on beta blockers, which lowers their heart rate and blood pressure. And what happens when they stand up? They get very dizzy. Yeah. Diabetes medicines can cause hypoglycemia, which makes them shaky and altered. So all these different chronic conditions, it typically, a lot of times, is the medicine that they have to take for it that can cause the problem. Okay? All right, do you understand the causes of falls?
Yes.
Okay. So now this is something that you might see. It's very, cute and fancy. But this is what we call like a fall risk assessment. Okay. So you put the patient's name on it. Okay. Increased risk of harm if you fall. So like if you were in the hospital and you fell out of bed, do you think you'd be okay?
No.
You don't think you would?
Oh, sure,
you look pretty young and healthy. Okay. So you're young and healthy, so you're probably going to be okay. But what if our 89-year-old Alzheimer's and Parkinson's patient fell out of the bed?
There's many risks.
And once an older person breaks their hip, they typically don't live very long after that. Even if we surgically repair it, the lifespan after a hip fracture is usually only like 2 to 3 years, if that. Okay. So would there be an increased risk of harm if that person fell?
Yeah.
Yes. Okay. So then you're going to look at these different fall risks. History of falls. If they've fallen once, they can fall again. Okay. We talked about medication side effects. Now, why would having a walking aid put them at risk for falls?
Maybe if they didn't know how to use it properly.
All right, maybe they don't know how to use it. Maybe you didn't put it at the bedside.
Oh, I heard also that the hospital needs to give you the walking aid, the thing, so the patients can't bring in their own, and so maybe if they are not comfortable using the hospital's walking aid, it can cause problems also.
Sure. Yeah, it's a new aid, and plus, if they're using a walking aid, it's because there's weakness somewhere, right? So they already had some kind of muscle weakness, whether it's half of their body or their muscles. IV pole or equipment. You've seen people trip over this? Yes. So any equipment or IV poles can put you more at risk. If you have an unsteady walk, and that literally could be from anything, right? You've had surgery, you're in pain, anything can cause an unsteady walk. May forget or choose not to call. So if you go into this patient's room and you tell this little old lady, do not get up without telling me. If you have to go to the bathroom, press this button right here and let me know, right? So let's say she presses it and you're in with another patient. And so whoever's answering call, it's like, okay, she'll be with you as soon as she can. And it's been 10 minutes, 20. And this little old lady cannot hold her bladder anymore. What is she going to do? She's going to get up and be like, you know what? You didn't show up when you were supposed to. Okay. So they may either forget they were supposed to do that, or they're like, oh, I'm not waiting for her no more. Okay. And they gone in. Okay. So we will do fall interventions, and we can, whichever one we think that they need. Okay. So it says communicate recent fall and or risk of harm. So you need to talk to the patient and make sure that they understand we don't want you to fall. So here are the things that we've put in place to make sure that you don't fall. You see this IV in your arm, it's connected to this pole. So if you try to get up on your own to go to the bathroom, it's going to either pull this out or you're going to trip over that pole. Okay. So we need to explain it to them. Okay. Which walking aids are they using? And we'll circle that. Okay. IV assistance when walking. So is it required that they have help with the IV pole? Now, some people, if it's a, 28-year-old male and he's just in because, he broke his arm or something, he can ambulate fine and he can carry his own pole. But if it's somebody who's altered or elderly, they're going to need some help. Okay. Toileting schedule. Now, this is most of the time people will fall because they have to pee and they're tired of waiting. Okay. So you need to choose which is the best for this patient. Is it a bedpan? Those are patients with no mobility. Like they can't get up. If they can get up, they need to be able to do a bedside commode. So that's what this assisted commode is. And another big testable thing is to make sure you put the commode on the patient's strong side. So let's say they've had a stroke and they're weak on their left side. I'm going to put the toilet on this side because when they step out, I want them to step out on their strong side, not on their weak side and fall. Okay? Or do they need assistance to the bathroom? And we'll usually put them on a schedule so that way we don't miss anything. So maybe every 2 hours we just pop in. Do you need to go to the bathroom? I have a few minutes. I can help you. Okay. Catching them before the need is way better than waiting too late and they just take off. Okay. What do you know about a bed alarm? Oh, yes.
A commode, is that just a portable restroom?
A bedside. The word commode means toilet. Okay. But in this case, this one that on this picture is a bedside commode. Okay. And so this has like a little potty hat in it, and you can just take out the potty hat and go dump it in the toilet. Okay. All right. What do you know about a bed alarm? Have you heard of it? You know what it is? No. So it goes underneath the mattress and it senses weight. Okay. So if all of a sudden the weight is not there anymore, the alarm will go off letting you know your patient just got up and they were not supposed to. I'm only going to use this typically if I don't have a sitter. Okay. But at least let me know, hey, they're trying to get up. Yeah. Because it notes a change in weight. Okay. And then you're going to figure out what kind of assistance they need out of bed. Are they on bed rest? What does that mean?
That they're supposed to be resting and
don't you get up. Okay. If they need just one person to help, so they may be a little unsteady. Okay. And just really important to note, that you're always supposed to stay a little bit behind and to the left of the patient. Okay. Yeah. Okay. You don't want to walk in front of the patient because you won't see if they're crumping out on you. Okay. So you want to just you're going to walk with them right behind them like this. Yeah. With your hand ready just in case they say they don't feel well. Okay. Or are they so unsteady that we need two people? Right? So you need to get the doctor's order for that. All right. Do we understand the basics of this? Yes. Okay. All right. So the next one is how to prevent falls in the hospital. Okay. So these are big select all that apply things that you may see. All right. So you always want them to sit for a bit of time before they stand. Okay. A lot of people in the hospital have what's called orthostatic hypotension. Have you heard of that before? So what happens when they change positions?
The blood pressure will instantly drop.
Yes. And then they start feeling dizzy. So let's say we've got a patient that's in bed and they're like, I need to go to the bathroom. I'm like, okay. So I'm going to help them to sit up, put their legs over the side of the bed, and they're just going to sit for a few minutes just to kind of get their blood pressure acclimated. Okay. Then I'm going to stand in front of them. And I think I went over this on the activity module. Their knees go onto your knees. Y'all's knees need to match. Right. Okay? But your legs need to be slightly outside of theirs. Okay. And then you can help them to stand. But you always want them to sit for a little bit, and that's just to regulate their blood pressure. Okay? Use a stick or a walker or cane or something when they're walking. You should know that. Keep the call button near. You should know that. Handrails in the bathroom and show them where the little emergency thing in the bathroom is.
Is that if they need...
Yeah, you should see them in all the bathrooms and all the hospital rooms. It's like emergency. So if they're on the toilet and they're like, oh my God, they should pull that thing, and then it will sound a big alarm and you know that somebody's falling in the bathroom. Got it. Okay. Keep your surroundings free of clutter. You should know that one. And then there's the grip socks. Are you getting a feel for this? Yeah. I'm telling you, a select all that applies coming your way. Okay. I could not get this one to print out very good. It's missing some things on the side, but I'll go over the big stuff. All right. So this is things that you would talk to the patient about. Don't read it. Look at me. Okay. How would you tell, or what would you tell a patient to do if you were sending them home and they had just had a stroke and they were weak on the left side?
Make sure that if you want to use any walking devices, do it on your strong side, so on your right side. Okay. Get rid of any rugs because you are using a walking device, but also for your own safety. Make sure it's all free of any clutter in the way to get to your bedroom or to your bathroom, wherever.
It's winter time. What do you want to ask them if they have?
If they have.
We talked about it. They're in New York a lot.
Oh, if they haven't any heater that's in the hall, and then if anything,
space heaters, heat. Yes, very good, very good. In the bathroom,
handrails,
grip bars in the shower and next to the toilet. And if they're really unsteady, sometimes we'll put them in the hallways too, so they have something to kind of grab onto, and make sure it's very lit in the hallway. Right, we want adequate lighting in there too. And that they always have their glasses, their hearing aids right next to the bed, because remember, sensory deprivation makes people very disoriented. Yes. Okay. All right, I love algorithms. I'm obsessed with them because they help so much on exams to know exactly what to do and when. Okay. So we're going to walk through this algorithm for fall risk assessment. Are you ready?
Yes.
Okay, me too. I'm so excited. Okay. So patient completes a state independent brochure. So this is basically like we want you to be able to be independent, but if you get to the point where you're falling a lot, that's a huge risk for you, and we want to try to decrease that risk. Okay. So you're going to ask questions like, have you fallen in the past year? Why are you asking then?
For the history of falls, if they fell once, they're gonna do it. Might do
Exactly. How many times and were you injured? I want to see how bad was that fall. If they were like, oh, I broke my leg, right? That's a big one. Okay. Do you feel unsteady when you're standing or walking? What do you think's wrong with your patient? They're all of a sudden they stand to walk and they're kind of unsteady.
Could be the blood pressure.
Could be the blood pressure issue. Sure. Do you worry about falling? Okay, because if they're worried about falling, they may not ambulate as confidently, right? Think about if you're every step you take, you're worried you're going to fall down. You're going to be very timid, and maybe it might make you more unsteady. Okay. So if they answer no to all these questions and we're like, well, you go with yourself. Things are going great. Yeah. Okay. Why would I put them on vitamin D and calcium? These are old people, by the way.
Calcium is like it strengthens your bones.
All right, and the only way to absorb calcium is through vitamin D. Yes, okay. And then I'm just going to say, hey, stay as active as you can. The more exercise you do is better. You go with yourself, okay? If they score like, oh, yes, they're answering yes to these questions, I'm like, oh, you're at risk for falls. Okay, so we are going to do a couple of assessments to assess their gait. What does their gait mean?
The balance for when they walk?
How they walk. Okay. Exactly. A gait is a walk. Okay. Any strength problems, any balance problems. Okay. And then if they've had more than 2 falls, then we need to do a full physical exam and find out what's going on. Is it their medicines that causing this problem? Is it the orthostatic hypotension? So we'll do a full medicine review. What's a cognitive screen?
Maybe impaired ability in their brain. Maybe they don't process things like aphasia.
Okay, so let's say that we did a cognitive screen. We found out the patient has Alzheimer's and they live at home alone. And so they wake up and they look around and they're like, this is not my house. I don't remember this house. Would you not freak out? Yeah. And so when they start freaking out and then they're trying to get out of bed very quickly and then they're more at risk of falls, right? Okay, feet and footwear. What needs to be on their feet in the hospital?
Grippy socks.
What about at home? Obviously, they're not going to wear grippy socks at home. What's the best way to prevent falls at home to put on their feet?
Shoes.
All right, so they need to be firm-soled. That's very important to have that adjective. Write that down. Firm-soled shoes. Okay. Firm-soled shoes. We don't want like, how do I explain this? Have you ever worked at a restaurant?
No.
Okay. When you work at a restaurant, you have to wear like non-skid footwear, like to make sure that you don't fall. But it also has to be very firm on the bottom so you don't slip, right? Anything that's soft on the bottom is gonna cause a problem. Right. Okay. Use of mobility aids. So we're going to make sure that they know how to use their cane and walker. I'm telling you that will be on your exam. It's in your activity module. All those teeny tiny details, 2 inches away from your feet, 4 inches to the side. All of those are very, very testable. Which foot goes first? Does it go on the weak side or the strong side? And each mobility aid is different. Okay. So make sure that you study those pictures I gave you in that module. Okay. What's a visual acuity check?
I don't know what acuity means.
You ever gone to the eye doctor? Yeah. We both have glasses, so we probably have. Okay. And then they make you stand in front of that E-T. Yes, that's visual acuity. Why am I checking their visual acuity?
If they can't see their canes and things like that, or if they can't see the side rails in the bathroom.
Yes. So we know that vision problems increase risk of falls. Yes? Okay. All right, do we understand kind of how we're going to do this fall risk assessment? And you have to fill out a fall risk assessment for every patient that you take care of. Whether they have any risk factors or not, this is a requirement for the chart. Okay? Any questions on falls and preventing falls?
No.
Okay. I sent it to you yesterday. All right, these are the types of restraints. Now, for nursing school purposes, we don't want to put anybody in restraints. How come?
It's just
claustrophobes them. They're scared. They remember they wake up not knowing where they are. Remember I told you that was my worst nightmare, is waking up tied to a bed and not know where I am. Like, you know how many horror movies we've seen that in? Halloween movies. Okay, where you wake up, you're in a hospital, somebody's performing something medical on you and you're tied to a bed. That is so scary. So in nursing school, there just is a typical rule, like, we don't put patients in restraints unless they are a harm to themselves or a harm to others, and that has to be fully documented. It can't just be your opinion. Okay. So we're going to look at the different types of physical restraints. Now, there's two main types of restraints. We've got physical restraints, and then we have chemical restraints. What are chemical restraints?
I guess probably would do something with medicine.
Yeah. You ever seen like I'm sure you've seen it in the movies at some point. A patient's in the psych hospital and they are freaking out and they're punching everybody, and the two big guys come out and they restrain them and they give him a shot in the leg and then he goes, You've seen that? Okay. So chemical restraints is some type of medication to sedate them. Also completely against nursing rules unless the patient is literally like trying to harm somebody else. Okay. But physical restraints is typically what you'll see the most questions on. All right. So in physical restraints, you can see we've got vest and jacket. Now, this is a big deal. This is like...
Isn't this like a straight jacket?
Yeah, like a straight... So they would have to be like under... I mean, you done some bad things to put them in that, okay? Now, the mitt restraints I actually love because I do pediatrics mostly. But the mitt restraints are fantastic because you don't actually have to tie them to the bed. You can just, they look like oven mitts actually to prevent, that's for people who are pulling out their tubes just because they're so confused. So I'd rather do that than tie someone to a bed, because when they wake up and I had oven mitts on, I'd probably more laugh than feel like I was scared. You know what I mean? So the oven mitts are great. All right. Now, wrist restraints are a big deal because you think when people are confused, they're gonna pull against it. Now, what could happen?
It just hurts their arm.
All right, so it could cause neurovascular issues. It can cut off circulation to their hand. It can cause injury to the bone, to the nerves, to the tissues. So we don't like to do those unless we absolutely have to. Now, the belt restraints. You got tied down to the bed, ma'am. So you were doing something very not okay. I've actually seen them use this in like if people are acting like horrible at an airport. I've seen them use this before because if I have to transport them a long way, okay, like you've seen those TikToks of people that threw an absolute fit and they're throwing themselves on the ground because they didn't get to go on the plane or whatever. And so if they have to transport them over a long distance, those people are just going to jump off the gurney. So they will belt restrain you onto the gurney. Like they're not playing. Okay. Tray tables are lap buddies. These are for people who try to take off out of the wheelchair. Okay. So it's like a little, like a little roller coaster thing that comes down, that keeps you kind of buckled in. And then when we're talking about restraints, they may ask you about 2-point versus 4-point. Now, we always want to try to do 2-point. The number means how many of them you have and where they're located. So we always start with hands. And then let's say I have done 2-point restraints and the patient is still kicking me, like actively kicking me. You get 4-point restraints then. Okay. But you have to like massively document why they got 4-point restraints. Okay. So a person may get 3-point restraints if maybe one of their legs just doesn't work, and so I don't have to worry about restraining them. Okay. But they were kicking me with the other one. So you see what I'm saying? So these are the type of physical restraints. Now, remember, restraints we do not do unless there has to be an order, and you better document the heck out of it. Okay. Otherwise, you are restraining somebody against their will, and that's against the law. Okay. All right. So here are the main rules for restraints. Okay. All right. These are restraints are physical devices to limit the patient's movement. Okay. What does that say?
Restraints do not prevent falls.
Yes. So if they ask you in a select all that apply, like which of the following would you do to prevent falls in your patient? It's going to say grip socks, clear the room of any clutter, keep the IV pole out of the way, all those things we've talked about. And then it will say apply restraints as needed to prevent falls. Do not do that. We do not restrain patients just to prevent them from falling, and it actually increases the risk of falling. Why would that be?
They can be confused. They don't.
Yeah, and then you wake up, you're tied to the bed. They will try to get out of that bed. Okay, so remember side rails up times? 2. 4 is considered a restraint. Okay, this is a big testable one. You can only use the quick release or slip knot. We don't tie a square knot, because if they're in the bed and let's say they've been pulling so hard and now they start bleeding, I've got to release this very quickly. So I need a quick release slip knot, and I'm going to pull that knot. If I tied a square knot, I'm going to have to go like this to try to get the knot out. Meanwhile, they're spurting blood from here. It has to be a quick release or a slip knot. And we only tie it to the bed frame.
So that way they can't get into it. the patient?
Well, the reason we don't do it to the side rail, because what happens if somebody comes and puts a side rail down?
Oh,
It's going to
yeah,
suck
it
their
hurts.
hand
Yeah.
into
Right,
that,
right.
right? Because the side rails can move, the bed frame cannot.
Oh, okay.
Okay, so that's why you tie it to the bed frame. There are often lots of questions on just that statement.
Mhm.
Okay. You always need to consider alternatives, because restraints are scary and they're pretty
Mhm.
awful, because here are the different consequences that can happen when you restrain someone.
Mhm.
It increases the risk of
Falls.
skin breakdown where?
Their wrist.
Their wrist or their ankles,
Oh,
depending
yeah.
on, right? What are contractures? You heard that word before?
Yeah.
So this is one of the consequences of immobility. You'll learn it in the activity module.
Okay.
So if you do not use your muscles, they will eventually just start to get shorter on you. You ever seen somebody in a wheelchair like this?
Right.
Or little old people that are all curled up?
Mhm.
It's because their muscles, because they weren't stretched and used, they actually contracted. And once it gets like that, you can't fix it.
And
They're
that's
stuck like
because
that forever.
The restraint, maybe.
They're
Okay.
stuck,
Got it.
right? They're tied
Mhm.
to something, and so you can't do range of motion like
Mhm.
normal.
Got
Okay. Incontinence, because they're not getting up to go to the bathroom if they're restrained. Now, you have a legal requirement to ask them every 2 hours if they want to be released and go to the bathroom.
Okay.
You can still restrain them back when they come back, but you have to document that. And even if they say no, you still have to document that you offered it, because if you tie somebody to a bed and do not offer toileting, you are taking away their basic rights and you could be charged criminally.
Mhm.
Okay. All right. Why would it increase the risk of depression and delirium?
Depression, I'm not sure, but delirium, that's
Well, if
like.
I tied you to a bed for 2 weeks, do you think you'd be kind of depressed?
Okay, well, yeah.
Yeah, you're not going anywhere. You're not
Yeah.
getting ambient. All you're seeing is a ceiling all day long. That's
Mhm.
depression. What is delirium?
Isn't that just slowly goes crazy?
They kind of go crazy.
Okay.
It's usually in a hospital situation,
Mhm.
because think, if you're just laying here staring at a ceiling for hours and hours, you don't know whether it's day, you don't know whether it's night, everything's beeping, they're giving you medicines, you're going to go crazy, right? Also, that it goes with anxiety too. What is aspiration, and why would they have an increased risk with restraints?
Aspiration, I'm not sure what that means.
It's when have you ever choked on your water?
Yeah.
Yeah. So when you choke on your water, it's because people always say it went down the wrong pipe, right? Okay,
Yeah.
that means it went down your trachea. And so part of that water actually gets sucked into your trachea, which goes into your lungs. Okay, so why would they be more at risk of aspirating like saliva?
Because the restraint was on them, and it goes down the wrong thing, they can choke.
And most of the time when they're restrained, they're not sitting up restrained,
Right.
they're laying flat.
Right.
Have you ever tried to drink water laying flat?
Mm-hmm.
It's not easy, is it?
It's bad, yeah.
It's bad. All right, so these are the assessments that you have to do for restraints. Okay. Every 15 minutes you have to do a neurovascular check, and that has to be documented. So how would I do a neurovascular check?
Inspect their veins, make sure that the restraints are not tight enough.
All right, so I need to check the 6 Ps. Have y'all talked about the 6 Ps before? Do you know what I'm talking about?
I've seen that in Epic.
Okay, the 6 Ps are, you'll be tested on this a million times in nursing school, so I'm going to go over them with you really quick. Okay, so the 6 Ps are things that you're going to check anytime you want to check somebody's neurovascular status to make sure that their arms and legs are getting perfusion, they're getting blood flow. Okay, so you're going to need to memorize these, because you will you'll have them on a million tests. Okay. Number 1. All right, what do you think an extremity would look like if it was getting no blood flow?
It just cuts off. It would get bluish, maybe.
Blue and then turn white. What is white called? Starts with P. If somebody okay, that actually is a good choice, but actually the fancy word for it is pallor.
Oh, okay.
Right? Yeah. So PALLOR, that's your first 6P, and that means that the extremity will turn a white color. Okay. How else might you tell something is not getting blood flow? When I touched it, what would it feel like?
Really cold.
Really cold.
Mm-hmm.
Okay. That's not a P, but we'll get there. All right. How might it feel to them if it's not getting blood flow?
To them?
Mm-hmm.
They won't feel it?
Okay, have you ever you wear little ponytails in your hair?
Yeah.
You ever left one around your wrist whenever you go to bed? What does it feel like? Have you ever woken up at nighttime, you had a ponytail around your wrist, and you're like, oh my God, it starts to tingle. That is paresthesias. So they may have tingling of that extremity, which is called paresthesias.
Tingling.
Mm-hmm. Or numbness and tingling is what they call it. Okay. What if they can't move that extremity at all? If you're like, oh, hey, let me take this restraint off, and they're like, I can't move it. Mm-hmm. It is
paraplegic?
Paralyzed. Oh. Paralyzed. So paralysis is the next one. All right, so what do we have so far?
Pallor, paresthesia, paralysis.
Okay. Before the limb dies, it hurts really bad, right? Like dying tissue hurts, so that is pain.
Okay.
And that would be pain out of the normal. I mean, of course, everybody's going to have pain in the hospital, but it would be pain out of the norm. Okay. Pain, pallor, paresthesias, pain. Okay. How do I know if this extremity is getting blood flow? What would I assess?
Check their pulse.
Pulselessness. Okay. So if there is no pulse, pulselessness.
Listness?
If I said somebody was dead, I'm like, oh, they're pulseless, right?
Okay.
And then add NESS. So pulselessness,
okay,
right?
Okay.
To have a pulse, you're pulseless means you don't have one,
Right,
and then pulselessness, yeah. All right, where are we at? How many do I have? One more. Okay. We talked about feeling cold. I didn't want to tell you this at the beginning because I didn't want to panic you. It's called poikilothermia. Okay. You see why I didn't say it first? It's POIKILO. And then thermia. Think of it, and that one makes sense because thermal, it's cold. Yeah, it's a cold, dead limb. Okay. So every 15 minutes, you have to document that you did all of those and none of the, like, it's warm, he's got a pulse, he's able to move his fingers. You have to document all of that. Okay. If you're going to remove them from restraints, we take out one arm at a time. Because what happens if somebody's been so naughty that you have them strapped to a bed and then all of a sudden you take off the restraints? What are they going to... Right, okay. So you only want to take out one arm at a time. Let them, we'll do range of motion. I'm going to move them around, right? You have to do range of motion on them because they can't just be, right? So when I'm doing my neurovascular check, I typically will do range of motion. Okay. Every 2 hours, remember, you have to offer toilet and then you have to offer food and drink. If they say no, thank you, I still have to document. I offered patient to go to the bathroom, patient declined. Offered patient food and drink, patient declined. Okay. To say that you did do it.
Do their own toilet, food, and drink.
No, you have to do. Girl, if they're in restraints, it's for a reason.
But
so you
would assist them.
Yes, I would say like, hey, are you hungry? Do you want something to eat? And they're like, yes, I am. I go get them some graham crackers and I'd either feed them or take out one arm and let them feed themselves. You see what I mean? But you have to document that you offered it even if they say no. Okay. And then you cannot restrain anyone without an order. And the order has to be renewed every 24 hours with a new documentation of why they still need the restraints. So you can't just like, okay, so the doctor can't go in and say like, okay, restraint, 3-point restraints ordered for this patient. And then in 24 hours, just click renew order. You have to overnight have tried to take him out of the restraints and he swung at you. Okay. Or he pulled out his tube 3 times overnight. Okay. You have to document that we still need it. Okay. Document that you tried the least restrictive option. So I tried all kinds of other things, which we're going to talk about at the bottom. Okay, actually, let's just go ahead and go there. Remember, orienting the patient is the best thing you can do to help them not be confused. When they get confused, that's when they want to fight you. Okay, so here are things to try before we restrain them. Treat their pain. You ever known somebody in a lot of pain and they get kind of pissy and they get very confused and agitated and irritable? So treat their pain. Make sure that you're not missing pain. Rule out a medical cause. What kind of medical causes could make people like really agitated or confused?
I don't know what rule out means. Like,
rule out means I need to make sure that they're not just confused because they're just confused. That there's not something, a medical diagnosis I need to like assess and then rule out. Oh no, that's not the cause. Okay. So like, what are some conditions, medical conditions that can cause agitation or confusion?
Confusion, maybe. Just Alzheimer's.
Sure, Alzheimer's, dementia, delirium is another one, right? Electrolyte imbalances can cause people to be agitated, right? Like especially sodium imbalances, so make sure it's not something like that. Hypoglycemia can make people really irritable. So is their sugar low, right? So you want to try to make sure, like, I don't want to tie someone to a bed if they're really just have low blood sugar. That's horrible, you know what I mean? So that's what it means, is to rule out, to make sure I'm not missing a medical cause. Okay, so how can I prevent them from going into restraints? Let's just chill everything out in here. Okay, so I'm going to turn down the lights a little bit. Okay, decrease the stimulation. If you've got crazy family members in there that are yelling and screaming, y'all gotta go. Okay, we're going to try to calm him down a little bit. Make sure the glasses and hearing aids are on him, right? We talked about sensory deprivation, how that makes people not only risk for falls, but it can cause confusion. Because if an older person wakes up, they can't see and they can't hear you, I'm going to be a little irritable. Exactly. Let's offer toileting. Sometimes if people have a full bladder, they may not realize they have a full bladder, but they just get like, you know how kids do? When they like start acting out and then you're like, what? do you need to go potty? And they're like,
Oh.
no, but they really do. Okay. Let's offer a beverage, okay? Or you may want to sit them in a rocking chair. Sometimes just that. We basically what we're trying to do is calm them down and orient them, okay? Some people though, when they get agitated, they need to walk.
Yeah.
So I'm like, okay, Mr. Jones, you're being kind of mean to me today. Why don't we go? You want to go take a walk with me in the hallway? Let's go take a walk. Okay, and you just kind of walk with them in the hallway.
Got it.
Okay, so I basically just I want to calm you down and give you whatever your sensory needs are before I just tie you to a bed. Okay, make sense?
Yes.
All right, questions on restraints.